We're going to bring Pat back up, talk about osteomyelitis, fifth metatarsal.
All right, thanks. Okay. All right, so in looking at this, it's crazy because I didn't get any more conflicts in the last 25 minutes. I do have a lot of internal conflict. If anyone can help with that. You got any good?
Did you get any more residents?
Yeah, no.
Okay, good.
I'm riddled with internal conflict. So I was looking at this thing. I was thinking, that fifth metatarsal seems very common for us to get into, to see trouble. And I mean, we take care of a lot of issues over there, right? Like fifth toe stuff and fifth MPJ things and partial fifth raise, and I mean, those are like a dime a dozen. You know, but every one of us has had this problem, and it is like the worst. I mean, I'm still trying to figure out what I don't like more, this or the heel. I think this probably, only because it seems to happen maybe in people who might have a little more time on this earth, I guess. I don't know. A lot of the heel wounds are, you know, renal disease and kind of, I don't know, just probably being a little more palliative for a lot of this is a little stinker though, for sure. But in looking at it, you know, there's a lot of literature about a lot of things, especially with, you know, the way the internet is now, and then I look back, you know, it's fun to come to things and see people put up whatevers, and after being at that university for 13 years and seeing a lot of papers from our place and lots of other fine institutions, there is zero on fifth metatarsal base, which is crazy because we all see it, but I think we must all just, you know, I don't know, just let it go or whatever. But we all know that when this thing comes in, you got this patient's got this start of a fifth met base problem. You're like, oh no, oh, that's going to be impossible, because we all know the problems with it. It's a biomechanical problem. It either started that way with some, you know, metaductus kind of foot, or, you know, maybe there was some other trauma or amp or something, but, you know, it is almost impossible to control. And that gets, you know, the peroneus brevis is not doing its job, and now really is not going to do a job, and the long-term sequela of this, so it is really something that is a real problem for us. But it's crazy because when I looked, it's like almost nothing in the literature on what to do with this thing. So the fifth metatarsal is really a conundrum in and of itself, which I think I am also one of those things. But, you know, you think it's something else like a fifth metatarsal fracture. We all get 15 Jones fractures a week because the ER thinks everything's a Jones, but they come in and it's a dancer. You're like, oh, nobody does anything with that. And then it's Jones fracture, like third patient of the day, it's like, it's a avulsion. Nobody does anything with that either. This is a waste of my time. Like, Jones fracture is the only one that we care about because avulsions and dancers take care of themselves. So they don't need us for anything other than, you know, you can make some DME with a boot if you get that. I'm not allowed because it won't let me, but so I don't even win in that war. So the fifth metatarsal is so freaking difficult because it's like this, half of it nobody cares about, and then there's only these one little thing. So for fifth metatarsal, like osteomyelitis, so you get a fifth MPJ thing, you take the head out, it usually heals. You get this thing, you're like, oh my God, it's a nightmare. So how can this metatarsal be so different when it's only a few centimeters back? It's really annoying. So the fifth metatarsal head is very easy. That was also probably a first year, you know, which is why it looks still like that. I guess the biggest problem is, you know, whether or not the toe, do you do anything with it or not? I mean, if it's still there and it's living, I would leave it, I guess. I mean, you can be cute and do a fillet of toe, or maybe if it helps. If it doesn't help, forget about it. You know, so what do you really do with those things? And, you know, typical MRIs of them. We've all taken out 1 million fifth metatarsal heads for people who come in with problems, or done some rays. But, you know, as you see, there's only really, when we go through this stuff, there's only a paper or two that really looks at fifth metatarsal stuff. A lot of the fifth metatarsal base will come from, or has a lot of sort of partial fifth ray amps too. So, you know, we do a lot of partial fifth rays, and a lot of them do okay, and we don't get into too much trouble, but a lot of them also progress, so we gotta kind of pay attention. So there are some kind of high reamputation rates. Well, in general, we know that with toes and things, and I guess if you think you're doing surgery on any of these people, typically, we're talking sort of neuropathic and diabetic, and even with these Charcot people, like if you do this big Charcot reconstruction and you get that to heal, don't think they're not coming back in a few months with another problem. If you think you're doing these surgeries and you are never going to see them again, you are sadly mistaken. Because if they came in with a third toe and you did a partial toe amp, you know they come back 6 months later with the other fifth toe or something. So this is a patient population that is going to come back. So don't think you're a failure if you do some great reconstruction and it does pretty well, but now they come back with, their second toe is curled and now they have a osteo there. I mean, this is a population that's going to come back. I don't think you can consider those things failures. It's that population. For some reason we get in our head that I'm gonna do this big, huge reconstruction and when it works, I'm never gonna see this person again. You're not in that kind of profession, that's for sure. How many people follow up with their vascular surgeon? 0. How many go back to, whatever. Infectious disease, forget it. They write us a couple scripts on the thing and they're like, get a, sed rate every 2 weeks and we'll see them if needed. So we seem to be the people who see them all the time. It's just the way that it is. So, don't think that after this big reconstruction you're never going to see these people again, because it's not true. But, the partial fifth ray is a pretty common thing for us and doesn't generally, like I say, cause too much trouble. But, there can be this progression of depending, and it is a patient population that comes back. So it's, things to think about. But, it's pretty simple to cut that out. There are only 1 or 2 articles, believe it or not, and Troy Buffelli is one that has, like, the only ones that are out there on fifth met ray. But, it's a pretty typical thing, or some cute little, zippy doos here that you can do, and you can fillet things and whatever. But what you really get into trouble with is this freaking fifth metatarsal base. So this is clearly much more challenging. And like I said, there's almost nothing there. And I find it really, for the most part, this is going to end up being staged because they typically come in and they have an infection. They come in, it's big and red, and you're cutting out bone. And so you're going through the same process you always do. This is, some beads packed in here. And we see this as part of amputations too, as we'll see a little bit later. But I mean, the thing is we can get some of these things to heal, but I have really gotten away from some of these other amputations only in the sense that because then they are immediately back. I mean, if you do like a Liz Frank or something, they are immediately back, and or you have to be planning for that. I mean, it's almost impossible to brace some of these people. Now, if they're wheelchair bound and they have a twisted up foot, not a big deal. But if they're wheelchair bound for a while and I can get this to heal, I mean, this sort of Liz Frank amputation thing here is really going to be a problem, as they start trying to now rehabilitate this guy. So he's in a facility. He's now healed up. He had a bunch of other problems and whatever. So I got this to heal because he was pretty much bedridden for a little bit. Well, now they're going to start getting him moving and start wanting to do PT, and they start wanting to do, well, now this thing's all curled up. Well, what's he going to do when he starts walking on that? He's going to be right back with a problem. So this is the problem with this fifth met base thing, and I sort of struggle with all the time. What do I do with some of these, So there's some loss of peroneus brevis, obviously, whether that was something, before or after, maybe I did it. So you can physically lose it, so we can cut it out, or, this fifth met base wounds that came from maybe some metaductus problem, some Charcot problems, obviously. Or there's other etiologies too. We have a lot of loss of power from neuromuscular problems, and we have a big, Mercy is the brain injury unit for the university, so we have a lot of people there who have some cavovarus problems and lots of muscle imbalances from all these, head injuries and things. So, it's not just diabetes, it's not just whatever. So there might be some other things in your armamentarium for someone like that, but generally speaking, we're losing, our peroneus brevis. So we lost power, we get a deformity, and that continues, and that's really where you get into issues, right? So we have a deformity that's going to continue to overpower and cause a problem. It's going to cause a lot of failure. So like I said, you might get that skin to heal in some sort of amputation, but relatively quickly they're going to start to have issues again. So we can try to brace, but we have all seen someone who's in a brace for a cavovarus thing, but now they're seeing you because they have a wound from the brace. So the brace can work for a little while, but typically these are kind of chronic and continual, and they overpower, and now this big plastic brace is making a wound. So bracing is certainly an option, at least initially, and you might get 1 or 2 that you can kind of keep that way. Some tendon transfers, and as I trained, that was things that we tried, and the only articles on fifth met base that I can find, that's what they talk about. And then fusion, for which I like, or what I call sort of internal brace, which has nothing to do with any kind of suture material, but it's bracing inside, so I get rid of the need for a big plastic brace, which is why I have so much hardware in a lot of my Charcot people. I'm bracing them internally instead of externally with a big crow boot or something for the rest of their life. So as we go through a couple of these things, so bracing, again, many times it's going to fail. It's a hard thing on skin. So this was a gunshot victim who has, now he's getting a fifth met because he's got this plantar flex problem, and he's got all these skin grafts from his compartment syndrome, and so it's this continued deformity on that hard plastic that's going to give you trouble. Fifth met head, fifth met base, and you need to maintain this, and the brace can't really do that for some. So tendon transfers, which one? Will you reattach the peroneus brevis? So what if you do some Liz Frank amp and you have a peroneus brevis sitting there? So what do you do with it? Do you reattach it right away in the face of infection? I mean, you're doing these a lot of times in infection. So do you want to reattach a tendon with what during infection? Do you want to put some sort of anchor? Do you want to put some sort of suture? Maybe not. So most people kind of don't want to be putting hardware where there might be some infection. So that's a problem. Maybe some other kind of tendon work. And I cut an awful lot of PT tendons because obviously the antagonist is the posterior tibial tendon. So I cut a lot of them. I make a little incision just proximal to the medial malleolus. It's very easy to find. And I just make a little Z and I let it go. I don't suture, I don't do anything, just let it go. So sometimes that's part of my sort of surgical staging process. If I have this big wound, I will cut that so I can get the foot back out and things, but I still hold it with fixators and whatnot. But I think cutting the PT tendon for me has been a relatively useful tool. But what to really do with this thing, and like I said, the only literature out there on what to do with this is from Troy Buffelli, and he has 2 articles, but they're just a couple years apart because it's the same patients. It's really like excising the whole entire thing, and then putting in some beads, and then coming back a couple weeks later, and you can always tell it's Troy because he does these weird little things. And he comes back later and then transfers tendon. So it's a 2-week later thing when he comes back because the beads are only going to be working for 5 to 7 days or whatever anyway. So coming back later, but it's a problem. Now 14% of those 21 had a positive cuboid culture at the time of surgery, the second surgery. So you have 14% of them having infection there, and you're still transferring a tendon in that area. Again, what are you going to anchor to? What are you going to anchor? What do you want to use in the face of a bone infection? Or do you wait longer? The problem with waiting longer is, where's the tendon go? Can you pull it back down? Can you move another one? Now it's another surgery, but it's months later, and so that's always been the problem for anyone who's dealt with peroneus brevis. I tried that as a resident with my tendons. We would kind of tag the brevis, come back a couple months later, try to find it, doesn't really work. How do you anchor it in this crappy bone? But when you look at his 21 patients, 47% of those had a partial fifth ray before the rest of the ray became a problem. So I mean, that's kind of impressive. And when you look at the other numbers, 10, so almost half from a percentage standpoint required further surgery, some pretty big ones. So his 3-year limb salvage rate was 76%. That actually depends on what you are defining limb salvage as. So most people define limb salvage in this world of sort of show part and distal. If you can keep show part and distal, that's considered a salvage. So anything more than that is typically not salvaged. So, I mean, it's not great numbers. One other case series, looking at 3, one died and the other one had a leg on a banana peel. So, I mean, it's not great literature out there about what the heck to do with this freaking problem. Now, I've tried it, and I have one nice x-ray, but that's it. That's the only one I could find out of 13 years of being at the university, of doing a tendon transfer on someone with no fifth met base. And I've definitely cut out more than one. So, but that's the one I could find. If I do them, then I generally will do something like this, because this is a bicep button. This is a button, endo button. It's still suture attached to it, and there's still metal on the other side, but maybe keeping bigger anchors or something. But there's still foreign material in there, so when you're anchoring something in an area that maybe had some trouble, may or may not be the bestest idea. So thinking about other things. Yeah. Okay, so what I generally end up doing is some sort of fusion now. I think for me, like most often, at least where I come from, it seems to be the most reproducible thing. Generally it's always staged. I did learn that you need to include a TN, which I would imagine it doesn't take anyone in here half as long to learn as I did, because you guys are all a lot smarter than me, but of course you got to include that, dummy. But at first I was just excited not to, I don't know, just do whatever, and then I realized that, boy, that really needs to be included because you get some ridiculous looking mess. And the way I do it, generally, I'm able to keep the hardware away from my lateral side, so that's the side that you're usually most worried about, depending on other pathology, other Charcot things going on. But if this is the infected side, whenever I'm done, all my hardware is on the other side, so not maybe in as much trouble, but could be. So the fixer is still going to be a very useful tool because, again, holding this big mess together, and then dealing with this side over here. So the fixer is going to be similar to what you saw because you really, really, really should try to do things in life that are reproducible, right? So if you're going to do a head osteotomy, you make the same incision and you pull the tendon the same way and you make your same capsule and you release. You do things the same because that's how it's reproducible. It's also you do things the same because that's how you build up speed and it can be done. So why would I do something that much different? There is, for most surgeries, 80% or so is the same every time. That part you should be very good and very efficient at. That is what you're trying to do. Be good and efficient at the part that is always the same. You don't want to waste all your brain energy and the little bar you had for breakfast and all that. You don't want to waste all that on the part that's mundane and easy and reproducible. That's what you're supposed to be training and learning. You need to spend your time and your energy on the part that's different. There's always something a little different. A little cut here, a little something there, the wound's over here, this is over there. I got my fixator, 80% of that's the same every time. The tibial block's the same every time. The way I throw my wires is the same every time. Because then I can play around with the front part. That takes a couple extra minutes, but I haven't wasted all day on the part that should be the same every time. You shouldn't be wasting 2 hours on putting pins in the tibia. Your problem's down there. You got to get down there and get going. Can't spend all day. So it's all the same, and I can work on this. So, because again, I can take a problem, pretty ugly, disgusting problem, and within just a week or two of being in the hospital, you see the wrinkles, you see, you can get, that one's pretty much gone, and this one's nice and healthy, and if you want to graft it, go ahead, but I would just leave it in there and let it go. But I did learn, again, that you have to do the TN, because what I used to do is I would, kind of try to correct and swing around and, do something here. Got no fifth ray. I don't know what's going on there. It's probably third year did that. I find, generally speaking, that the third years are the worst at toes. I'm just saying, Jason. You guys are the worst. But, so I ended up with this fifth ray in stage, and everything's healed. And I came back and did a TTC because she was kind of this cavo-varicose thing, and I just did a TTC, and it held it up there. But very, 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 very quickly, the foot immediately rotates on the TN joint because I have a PT tendon still working, and I still don't have a peroneus brevis. So I locked up the TTC thing, but I didn't do the TN, and that just, that makes no sense. Of course you got to do that. So that was stupid because it just fell apart and broke apart right at the show part and just came, right back. So, that was a dumb idea, the one I had in my whole life. So, but what I generally do now is I get these kind of things where people get so nervous because they just start get little rat bites in here because they're very, very, very nervous about this area. But by this time, you might as well forget it. I mean, Tim Burr, that thing is coming down. That's like that little guy's hanging on by a thread there. So, but this is frequently what you get sent. I have to show you the email I got from somebody who's referring me. Somebody says, Pat, I took the liberty of getting some x-rays in the office. The good and the bad news is the ankle doesn't look too bad. Has some arthritis, not the worst I've ever seen. I'm like, that's unbelievable, because that's what I say. That's not the worst I've ever seen. I got that thing, like, it's pretty funny. Not the worst I've ever seen. So this is the guy that's sent down. So he's had a couple debridements, not too bad, pretty clean looking. I also scrub it up a little bit before surgery, so it makes it nice and neat. So that's what you got there. You got this completely unstable, sort of problem. So I cut this out. Now, if I have an okay thing up here, sometimes I'll leave that because then I'm like I I'm like some sort of god or something, because the guy still has the toe. I mean, what do I really care if that toe's not doing anything out? It wasn't doing anything before. But it's really not part of the problem, so I'm okay leaving it. It's fine with me. But clearly back here has to come out. But you know, things are reduced and things are held in place, and you go through the exact same thing. So just like those midfoot Charcot things, this is exactly the same. I'm just in a slightly different area, and I'm making cuts maybe in a slightly different area. But again, the fixture is the same, and this is my midfoot frame, so all that ends up being the same. And then I go through my infectious disease things and you know whatever else I want to do. So there it is, almost closed. Leave a little bit open because it's there, but you know, a straight foot that I can then hold. But then I come back, you know, a couple months later after I did, so this is all healed, but it's still floppy because he still has no peroneus brevis. So I need to do something more permanent, just like before. But you know, you need to include TN, and that keeps that foot from, you know, going into VARS. So and then he can get around. I literally just saw this guy, you know, like a week or two ago, and he's had this thing for a few years now. So I kind of went to that idea of, you know, do these things, and if I can leave the toe fine, and you know, he can function just fine with that thing. So another guy with a pretty ugly base of the fifth wound, and you can see why, how it's kind of all twisted and contorted. So for these types, if I have some sort of deformity, I'll just do a similar thing, and if you want to put a couple wires for a guide, and I'll cut a wedge and close it down. So just like before, I'll just go this time's from lateral, and I'm cutting through that. I don't have a brevis, who cares? I know I'm not going to need it later anyway, because I'm going to do some sort of pan-talar or, you know, extended kind of thing. But if you have a metaductus or some sort of, you know, problem like that, then I'll just cut the wedge that way and swing the foot and just get rid of that whole thing. So it's the same idea, and then it's just pinned on that side, and the frame goes on. You just do the same thing, do exactly the same, come back, and then you do some sort of pan-talar, you know, however you really want to do it. This is a guy I had a combination of. He was sent down from our sister hospital up to about a mile away, which is crazy because they have me at Mercy and they have no one at Presby, and this kind of shenanigans goes on. So his fifth met is completely gone, and they were missing the whole rest of the thing going on, but they did have a vac on it, so that helps. So, but you know, you have multiple cora here, just like most things, and you know, dealing with all those cora, but no worries, I got a saw, so I can cut that out. Now, this is clearly still a problem, and I don't want to come back here probably and put screws, but I know that later, because this is this fifth met base problem, that I'm going to come back and do some pan-tailory type thing, and I can keep all that stuff, you know, medial. So, you know, same thing, everything's the same, all the time. So I take that and make it into this. But this is a crappy x-ray too, obviously, so it's not so ridiculously kind of plain, but that wedge is cut out from lateral in those couple pins, and then I'll pull those out, and then I'll keep all this, you know, over here medial, and just kind of stay away from that. And this guy's had this thing for years too, so it's just a way for me to kind of lock up that sort of cavo-varice problem. He doesn't have a fifth met base anymore, so you know, I can deal with not having a peroneus brevis, you know, with those things. This is the exact same thing, same but different, because this is the other foot, so I had to actually turn this way this time. Although, for those guys in the room who are with me, realize I don't do any of it, but I take a lot of pictures of you guys doing it. So, but you know, same thing. Just, you know, cutting that out for, you know, for a wound that, you know, looks like that. So same thing, and just pinning and holding and coming back and doing some sort of pan-talar. You know, it's really kind of the way you go. Now, there are a couple other, you know, etiologies too, and so this is just like that other sort of amputation I was showing you. This guy had gas all the way up his anterior compartment, so he had to release all that and then do a skin graft on that, and so he's got a mess. So he's got this Liz Frank amp, and he finally kind of heals things, but then he breaks down, because that's what they're going to do. And you know, after breaking down for a while, you know, those are his films, and he's dying. So that's what he looked like, you know, on the table, obviously, and then after. So, you know, correcting that in the face of a wound. So you can see where he's kind of been chewed up and beaten up, and sort of after his Liz Frank amputation, he had this wound, which turned into this little chronic osteo thing, but, you know, I kind of got him straight with this rod. That's where sometimes I'll put like an antibiotic rod. So, you know, Jason Woods is in, didn't you help me with that, Jason? An article on antibiotics. So sometimes I'll put antibiotic on my rod if it's in an area that I think, well, it's pretty close, and, you know, makes me feel better. I still don't sleep. That's for other reasons, I guess. But that's, him on a table. So even in the face of a wound, and then just within a couple weeks, it's already much better because his foot's not all contorted and twisted. And then, kind of gets better. And then this is just sort of a similar example. The guy gets sent to me, he's had a 5th ray, so of course that didn't work, and then it still has a wound. So then he has a 4th ray, and then that's certainly not making it straight. But all of us have had that. And you're like, oh, I don't know what to do with, this mess. I mean, he's got a huge wound, and this is a useless foot. There's something up here going on. So, I don't know. I could cut all this out. I don't really need these couple toes. So, and do something flat. So you can do something like that, and it'll heal, like I said, if you get this guy off it for some weeks. But then you're left with this. I mean, he's already crooked. I mean, he started crooked. So you're going to have a problem. You have no 5th Met base, so you're going to have this problem. So then they know they have to come back for another surgery, and you may not have the healthiest person, and that's why these 5th Mets are, they're happening in unhealthy people. So bringing them back, how many times you want to really bring them back, it's really a tough decision. So sometimes better off not having that leg for some of these people. But he needs to be converted into something, straight. So, he has this whatever show part, whatever thing, I don't know what's going on. But, we can kind of hold him, that way. Is it really something that, is useful? Well, he's can walk around in a crow, or he can walk around in some kind of bracing. And I guess at the end of the day, if you're keeping it where the guy can maybe get to the bathroom without the help of 4 or 5 different nurses, and just the healthcare sort of energy involved in some of these people that are a little bit bigger and they need help, just whatever. If he has a limb he can get on, I mean, some of that's kind of reasonable. Is it really changing their sort of mortalities? Probably not, but maybe make it a little bit easier during that time. So I mean, it is a consideration, but I think it's things that just really obviously remember and think about when you get those 5th Met base things. So I mean, in closing, obviously, that 5th Met is really a tough problem. I am absolutely amazed that there's literally nothing. So I mean, I've been thinking about this for a while, and so the guys are looking at all my sort of 5th Met based treatments, and to put that out there's at least an option. I mean, if you have something that's salvageable, you have a peroneus brevis that's not going to come back. I really don't think tendon transfers are really going to work that well, not in that kind of deformity that wants to keep going. I also think, I mean, for a lot of those, for certain populations, you also have to think about too, you're transferring a tendon in a relatively probably unhealthy person who's 50-something, 60-something. It may have been involved in some sort of osteomyelitis, and now you're going to transfer something. I mean, really, you got to think about tendon transfers sometimes in the person you're transferring. If I'm transferring a 60-year-old crappy tendon, is that really going to hold up to, other mechanical things that are going on? And so kind of addressing those. So for me, for some of these, difficult problems, it's been a useful tool to kind of stage, much like those midfoot things. So, all right, thanks everyone for hanging out for a little bit longer. We got one more about how to rehab these things.